Hello everyone. Today we will study the disease of the wrist and hand. I hope that you will combine the anatomical knowledge learned before with the following courses for a comprehensive and effective understanding. First, we will study distal radius fracture. According to the characteristics of our study on fracture, we will first understand the overview of the disease. Distal radius fracture is the most common fracture of the wrist and is common in the elderly and young adults. The distal radius has its very important anatomical characteristics. Please review the two important anatomical characteristics: palmar tilt and anal tilt angle. These relationships are often damaged upon fracture, and a normal anatomic relationship shall be restored during reduction. Next, let's look at the etiology, physiology, and classification. The site of distal radial fracture is mostly at the junction of cancellous and dense bone, which is mechanical weakness point. However, distal radial fracture is often caused by indirect violence. During falling, the downward gravity of the trunk and the upward counter force on the ground act on the distal radius, resulting in fracture. Whether there is disturbance in the fracture is related to the magnitude of the violence. By the injury posture and fracture displacement, we classify distal radius fracture into three types. First, I will introduce two common fractures. The first is extension fracture, also known as callus fracture, which is the most common fracture. For its posture during fracture, during falling, the elbow is at extension position and the forearm is in superior rotation position. The wrist joint is in an extended position. The palm touch the ground first, and the violence results in distal radius fracture. When the violence is mild, the fracture is inserted without obvious displacement. When the violence is large, the distal end of the fracture will be displaced radially and dorsally, and the articular surface of the distal radius will be changed to dorsal inclination, with reduced or complete disappearance of ulnar inclination and even radial inclination. The second is flexation fracture, also known as a Smith fracture. During falling, the dorsum of the hand touches the ground and the wrist is dramatically flexed, resulting in the fracture. The distal fracture end is displaced to the palm and radial side. The cause of this fracture is opposite to that of extension fracture, so it is also known as reverse callus fracture. The third is the longitudinal oblique fracture of the articular surface of the distal radius, accompanied by wrist subluxation, called Barton fracture. By the mechanism and fracture line characteristics, it can be classified into the following two types. The first is a dorsal marginal fracture, in which the forearm is in superior rotating position and the palm touches the ground when the wrist is at the extending position during falling. An external force causes the carpal bone to impact the dorsal margin of the articular surface of the distal radius, resulting in a split fracture of the dorsal margin of the distal radius, accompanied by dorsal dislocation or subluxation of the wrist. While the distal fracture fragment is wedge-shaped, includes 1 to 3 of this articular surface, the fragment moves proximally and dorsally, and the carpal bone is subsequently displaced, such as fracture is shown. The second is palm margin fracture, in which the wrist is in palmar flexation position and the dorsum of the hand touches the ground first during falling, resulting in a split fracture of the palmar margin of the distal radius, accompanied by palmar dislocation or subluxation of the wrist. Next, we will continue to study the diagnosis of the disease based on the classification. The key points of diagnosis and examination are the core of our whole process, which shall be mastered by everyone. First, general symptoms and signs are wrist pain, swelling, partial or complete loss of wrist function. Second, special signs. The first, extension fracture. The first is a special deformity on the lateral view of the wrist. When the distal end of the fracture is displaced dorsal, a fork-like deformity will be seen. On the anterior-posterior view of the wrist, when displaced radially, a bayonet-like deformity will be seen. These two special signs are the specific characteristics of extension fracture of the distal radius. In case of shortening displacement, the styloid process of radius that move upward will be palpable. Due to wrist pain, abnormal movement, and bony crepitus, although occasionally palpable, are general not examination specially. The third, examination. Anterior, posterior, and lateral X-ray of a wrist can identify the type of the fracture and the direction of displacement. The diagnosis can be made based on the history of injury, clinical presentation, and X-ray examination. So let's take a look at the differentiation diagnosis. In the next class, we will learn wrist-related soft tissue injuries. The swelling is often not obvious if there is no displacement or if the fracture is incomplete fracture. Only local pain and tenderness can be felt, and the important differentiation point with wrist soft tissue sprain lies in that there are ring tenderness and longitudinal percussive pain for fracture, while none for soft tissue injuries. Combined with the imaging examination, they can be differentiated obviously. Next, let's take a look at the treatment methods that have significant clinical advance for distal radius fracture in orthopedics and traumatology of TCM. In the treatment of distal radius fracture, general fracture without displacement or incomplete fractures require only palmar and dorsal splinting for 2 to 3 weeks. Fracture with displacement should be treated by manipulative reduction followed by fixation. Different reduction methods shall be used for fracture reduction based on the type of fracture. Next, let's watch a related video.
Reduction and fixation of the cause fracture. After anesthesia, the affected limb shoulder abduction, elbow flexion 90 degrees, forearm pronation, protraction. Correction of radial deviation by resetting, manipulation. Correction of dorsal displacement by lifting, manipulation. At the same time, the wrist joint was reset to the volar and ulnar size. After reset, use a small splint for external fixation. Maintain the reduction of the wrist joint of the affected limb to the volar and ulnars.
So in the video, extensive fracture reduction is taken as an example. In the video specially explains the reduction of distal radius fracture. Then I will emphasize again. The first is the preparation before fracture reduction, including preparation for personal body position, anesthesia, related material, etc. After reduction, we should adopt over-articular fixation as a fracture fixation method because distal radius fractures are intra-articular fractures. The upper end of the extension splint shall reach the middle and upper 1 to 3 of the forearm, and the distal end of the radial and dorsal splint should go beyond the wrist joint to restrict the radial deviation and dorsal flexation activity of the wrist. The fixation of the flexation fracture is opposite to that of the extension fracture, and the lower end of the radial and palmar splints should go beyond the wrist joint to restrict the radial deviation and palmar flexation activity. In medicine treatment, different treatment principles shall be adopted for different age. The principle of early treatment of fracture in children are promoting blood circulation to remove blood stasis and relieving swelling and pain, and oral medicines may not be used in the middle and late stages. Middle-aged people should be treated with medicines based on 3-stage syndrome differentiation. After relieve the fixation, traditional Chinese medicine fumigation should be applied to relax tendons and activate collaterals and ease joint movement. The vast majority of extension and flexation fracture of the distal radius can be treated by manipulative reduction and splint fixation with satisfactory results. If reduction and fixation fail, they can be treated by closed reduction and percutaneous pining, or open reduction and plate and screw fixation. For palmar or dorsal margin fracture of the distal radius, if the fracture fragment is large, unstable after reduction, and it is difficult to carry out split fixation, CRPP or open reduction and plate and screw fixation can be used. After reduction and fixation, the blood circulation of the hand should be observed, and the tightness of the splint should be adjusted at any time. Attention should be paid to keep the affected limb at the posterior rotation 15 degree or neutral position to correct the tendency of fracture redisplacement. Radial deviation and dorsal flexation activities of the wrist should be avoided during extension fracture fixation. For comminuted fracture, the fracture line passes through the articular surface. Poor alignment is likely to result in wrist dysfunction or lead to traumatic arthritis. So the fracture shall be correct aligned. The patient's limb function exercises shall be strengthened to avoid sequelae. Exercises training requires patients to actively do interphalangeal joint, metacarpal joint flexation, and extension exercises, and shoulder and elbow activity during fracture flexation. After fixation is relieved, wrist flexion and extension exercises and forearm rotating exercises shall be performed. So, the above is the knowledge related to distal radius fracture. Please review all knowledges. Thank you very much and see you later.